interesting and important mini symposium of IHRS web series. It is important why I'm saying this again and again is because this marks 1 year completion of the web series and grand round that we started in 2020 during the lockdown. And Dr. Sanjay Dikshit took the responsibility and he has done a fabulous job, over the last 1 year, creating these symposia, arranging for the faculty, talking to them. It's a lot of work. It's a lot of work he's done, and he has done it beautifully. All the recordings are available on the IHRS official website for you to see and believe what I'm saying is actually true. So thank you so much, Sanjay boss, and you've done a fabulous job. And today's symposium is atrial fibrillation, and he has combined the faculty from 3 continents to be here and talk to us. We have faculty from Australia, USA, and Asia Pacific, that is from India. So he's done a fabulous job. So over to you, Dr. Sanjay. And Preeti, I would request you to put everybody on mute except for Dr. Sanjay Dikshit.
Thank you, Vanita. Dr. Sanjay. That was very kind words. I mean, again, this has been a team effort, and obviously you've been organizing these on our behalf, and so congratulations to you. And I really want to thank the faculty who have, just given their valuable time and have agreed to participate without any expectations, for which I'm very, very grateful. As you said, we've been doing it for a year now, once a month, and in some ways, I think we've saved the best for last before we take a break over the summer. So we have a remarkable group here today that have expertise in the different aspects of AF ablation. So this is going to be an exciting morning, at least for us in the US, and an evening in India for those who could join us in terms of what we learn from the faculty. My co-chair, Dr. Shanter, we will be conducting this. And what I thought we would do is, since we have 6 faculty, we thought we'd split it into 2 groupings. So we'll have the first 3 speakers give their talks, and then we'll take a break for maybe 10 minutes to answer questions. And then we'll have the next 3 speakers come on. And then following that, we'll probably have maybe a little longer session in which we'll try to address questions both for those speakers and the previous group. And so I would encourage the members to please write in your questions, and we'll try to get to them. But with that, I'd like to bring in our first speaker, Dr. David Callans. He's professor at the University of Pennsylvania School of Medicine. He's the co-director of the Heart Rhythm program here at Penn. Together with Frank Marshalinski, he's really been, the brains and the brains behind the program that we have today. Personally, for me, Dave is a dear friend of 20 years now. I have no qualms in saying he was one of the reasons that I decided to come here for my training. And I also think he's one of the reasons why I have decided to stick around for this long here. So I really thank him from the bottom of my heart for that. Now, Dave has, obviously been a participant as well as some of the leader in designing some of our efforts. And so our approach to AF ablation with the Penn approach is a limited approach of pulmonary vein isolation, targeting non-PV triggers. And in our experience, that seems to work for all types of atrial fibrillation. And so I look forward to Dave sharing with the audience our experience and his thoughts about why it works for us and what the future might be of the strategy. So Dave, thank you for joining this morning, and love to hear your thoughts.
Sanjay, thank you so much for that wonderful personal invitation. And I really appreciate the chance to be able to present to the Indian HRS. Good evening in India. As Sanjay said, this is really our strategy, and it has been a very consistent strategy. We've tried some investigation against the background of this strategy, mostly led by projects that Sanjay has come up with. And it always feels like we're giving apologies for this. It's difficult when we accept referrals And, the referral will say something like, I tried PVI and there was a, there's a recurrence. I want to refer this patient to you. What will you do to add to this? And it's a little bit awkward to have to say, well, we'll do PVI, non-PV trigger ablation better than you do. And often it really does work, whether it's a first-time procedure or a second-time procedure. So PVI is the cornerstone of AF ablation. And I think that it's very puzzling to me, but this paper from 2002 still seems to influence our thought. So this was a very important paper at the time from Michigan that showed that in this era, segmental PVI with 8mm catheters worked medium well for paroxysmal atrial fibrillation and really not at all for persistent atrial fibrillation. Even PVI, in the acute PVI in this experience, was only 94% successful. So part of the story that I'm going to share today is that it's really difficult for us to continue relying on legacy experiences. I think technology has improved and our practice has improved so much that we really have to start thinking into the future and maybe even redoing studies based on our better abilities and better technologies. So this brought up in 2002 the idea, well, what do we do next? We make lines, we target fractionated electrograms, we ablate AF drivers, do we isolate the left atrial appendage? And these questions are still largely unanswered. There are problems with more extensive ablation. Linear lesions are difficult to complete, and sometimes even when they're acutely successful, maintaining that block is difficult. These lesion gaps that form or remain are proarrhythmic for atrial flutters, and many times patients are more miserable during atrial flutter than they were even during atrial fibrillation. There's an increased incidence of non-AF recurrence with other forms of substrate ablation as well. I think this is something that we know and conveniently forget, but extensive ablation results in reduction of left atrial function, which can be profound. And there's studies to show that this is so. I'll show one in a second. And yet we have this pull, and I feel it too, that if we just ablate more, maybe things will be better somehow. Finally, another inconvenient truth: if particulate matter is going to the brain, silent or otherwise, and this is related to ablation, how could more ablation be better? A reminder from the IHRS Expert Consensus on AF Ablation 2017, all of the PVI plus ablation strategies received a 2B recommendation, which is pretty faint praise, mostly based on the fact that there's very little randomized data to suggest that any of this is worthwhile. This is Atul Verma's very excellent work in STAR AF2, showing that the addition of targeting of cafe electrograms or adding lines to PVI really did not result in increased success. And in fact, the PVI group actually did better than the added substrate ablation group. Now, this is another opportunity to say that Atul is going to be updating this trial, just as we talked about before. Things have changed. Are these strategies helpful in the present day of technology? They may very well be, and I appreciate his efforts in trying to bring this forward with STAR AF3. Electrophysiology as a field, in the past at least, has always really reached back to our underlying understanding of pathophysiology when we've been confronting a clinical difficulty that we haven't been able to understand or to succeed with. So our pathophysiologic understanding of atrial fibrillation really goes back to Bordeaux. We understand very well how triggers from the pulmonary veins initiate episodes of atrial fibrillation. We would extend this a little bit, saying that non-PV triggers initiate atrial fibrillation in the same way. This is a very old slide looking at a series of patients that we did, looking at where these non-PV triggers occurred. So they're kind of, this is, it kind of looks like there's an anatomic pattern to this. In the right atrium, the ring of fire as it's been described, adding the SVC. In the left atrium, there are a lot of posterior wall triggers, which in the modern era would be eliminated by antral PVI. But even things like AV node reentry or unexpected AVRT can be an initiator of AF. And this is just important as the pathophysiology of PV triggers. And if they're not eliminated, atrial fibrillation is certain to return. This happens pretty frequently. In this series, it was 15%. It's probably more like 10% these days, but still a meaningful contribution. This is a study that Sanjay really championed, and it's kind of dated now. Again, this is 5 years old, and I think things have changed in the interim. This is a retrospective database review of 400 patients with non-paroxysmal atrial fibrillation. Consecutive patients were taken to achieve 200 persistent AF patients and 200 longstanding persistent AF patients who were treated with first catheter ablation at Penn from 2004 to 2012. The approach is exactly what we're talking about: antral PVI with ablation of non-PV triggers and either spontaneous or induced atrial flutters. The mean age was 68, the CHA2DS2-VASc score was 2.2. There were 524 procedures performed. So 100 patients had essentially one repeat procedure. Some had 2 repeat procedures. And follow-up was 3 years from the first ablation. So what we found were 3 groups that were determined by ablation outcome following the final procedure. Group A was free of AF recurrence, and that occurred in nearly 60%. Group B was very interesting and kind of the focus of this manuscript. Some of these patients with non-paroxysmal atrial fibrillation were transformed to having paroxysmal atrial fibrillation. And this was important in terms of clinical outcome because they weren't as symptomatic and they had much easier to manage paroxysmal atrial fibrillation. Sometimes these were short and even rare episodes, but they still counted as recurrence. And group C had continued persistent atrial fibrillation, and that was 15%. So interestingly, I'm going to take the left side of this slide first. There were univariable and multivariable predictors of failure to achieve long-term freedom off antiarrhythmic drugs after the last ablation. And they look like very familiar things. I want to highlight a couple of them. In the univariable predictors, congestive heart failure, obstructive sleep apnea, left atrial diameter, and body mass index were all very important. And I'm going to use this as a shout out to Rajiv in the following slide. But I think that we're not ablationists. We have to be physicians and take care of these other risk factors. And I think that more attention needs to be placed to this. On the right side of the slide was really the main point of this paper, that after first ablation, if people had paroxysmal recurrence, they were much more likely to have successful elimination of atrial fibrillation eventually, compared to if they had persistent recurrence. This is the slide. This is one of the many studies that Rajiv has contributed to looking at risk factor modification after AF ablation. This is ARREST AF. The risk factor modified patients doing much better in red than the non-risk factor modified patients in blue. This is really important, and I'm glad that he's speaking and giving us some more tips on this today. I think this is very valuable information. I think there might be another take on it. And when I think of my patients recently that have failed multiple ablations, many times they're with BMIs even greater than ARREST AF. So what should we do? In America, it's a big problem. Patients with BMIs and atrial fibrillation greater than 40. Is bariatric surgery prior to ablation the way to deal with this? And this is starting to gather some momentum. So this is our strategy. But what happens when it doesn't work? When people have recurrent atrial fibrillation, what happens next? So this is another in the series of studies that are suddenly a little bit dated. This is Mohammed Sadek when he was a fellow with us, and he looked at 1,045 patients who had ablation between 2003 and 2013, and 1,298 repeat procedures, 900 for AF and 145 for atrial tachycardia, atrial flutter. What he found in that era, and this is not true today, but what he found in that era is only 5% of these patients with recurrent atrial fibrillation had chronic PVI. So it's a lot different today with our technology, and it presents a new problem. But to make the point that in this series, in the absence of provocable non-PV triggers, if there was chronic PVI, empiric ablation in that 5% was less than 50% effective. We tried all sorts of different empiric strategies and didn't find one that rose above the rest. So the problem with this is that now this is happening all the time. After PVI and non-PV triggers, patients come back with atrial fibrillation and have completion of everything that we did the first time, and we're really not sure what to do. So there are some good ideas, and many of these will be discussed today. I really want to point out some of them that are going to be examined in multi-center clinical trials that are randomized. I think that's the only way we're really going to get past this gap in knowledge, so we know what to do when we're talking about PVI plus if it is necessary. Many of these ideas will be outlined by future speakers. So to summarize, we feel very strongly, very passionately about limited ablation for all types of atrial fibrillation. First of all, because many patients are successfully treated with PVI and ablation of non-PV triggers. I do want to add that everything that we're talking about may need complete reanalysis because our ablation technology and our practice is improving. So hats off to STAR-AF3 and other randomized trials that are going to bring us into the future of what our strategy really should look like. Treatment of recurrent atrial fibrillation in patients with chronically isolated PVs and no provocable non-PV triggers is presently quite empiric. I think that progressively aggressive ablation techniques should be subjected to evaluation in clinical trials. And I welcome the future because I think that's what's going to happen. Thank you so much for your attention.
Dave, thank you for that excellent talk and really getting us thinking on this subject that we often forget to do and just kind of do an ablation and target the veins and do everything else. But the thought behind the process, and thanks for bringing those points up. So I think what we are, for those who have just joined us, we are going to invite questions, but we'll save it after the next two speakers have spoken. So that'll give us a gap of about 10 minutes, and then we'll go on to the next part of the talk. So I'm going to invite our next speaker now, Dr. Sanjiv Narayan. Sanjiv and I are colleagues now for 20 years. In some ways, we are contemporaries. We came through our fellowship training around the same time, albeit at different institutions. Sanjiv also spent a little bit of time at VA Medical Center in San Diego, so we overlapped through that association in terms of forums where we would often come together. Sanjiv's background in biomedical engineering, his deep knowledge of the action potential myocytes, and so that has really allowed him to foster a very good understanding of activation during AF. And he has been able to take that to the next level and develop actually a tool that has allowed him to map AF activation. And through that, he has demonstrated through some remarkable experiments and human studies, the ability to identify triggers of AF. And I still recall the heart rhythm meeting in 2011 when he presented his data at the late breaking trials. And following that presentation, everybody felt like we had found the cure for AF. And there was just so much enthusiasm, excitement, and that technology has certainly allowed us to understand AF in ways that we didn't before. The early studies were very promising, but the subsequent experience has been somewhat variable. And so today, I'm so glad that Sanjiv has decided to join us, and he'll be addressing his own experience in mapping and ablating AF sources. And then he's going to talk to us a little bit about, the global experience with this, and whether that's still something we should pursue in every AF case, or is there a slightly different strategy that we should choose. So Sanjiv, I'd love to hear you speak to this, please.
So thank you very much, Sanjiv, again, for that very kind introduction. I'd like to thank Dr. Aurora Shenta and the rest of the organizing committee. It's just terrific to be here. Good evening, India. It's always a pleasure to follow Dave Callans, who really gave, as usual, a very thoughtful outline. So my talk today is mapping and ablating of AF sources, as Sanjay said, and can it be done? Is it worth the effort? Which I think is a very important question. As Sanjay said, this idea has been around for decades, technology has been around for about a decade, and here we are, as Dave said, without any clear road forward. So how do we move? I'd like you to just have a quick look at my disclosures at the bottom of this slide. But mapping is really central to our field. It's really central to all human endeavors. And if you look at mapping the globe from early experiences, Eratosthenes, 220 BC, through the age of discovery to the current day, the goal of mapping was really to find a path to a destination. So if we extend that analogy to atrial fibrillation, if the idea was take a rough idea of the possibilities, and we know what they are, some are of course established, PVI, others, as we'll discuss, and use that through mapping to steer treatment to critical regions. If that's the goal, then clearly we're not there yet, but we're somewhere in the or past the age of discovery. We've certainly got a direction. So over the next 15 minutes or so, I'm going to try and talk about a few of these topics. Why would you map? And the reason to map would be really to identify ablatable targets. Because if the concept is that AF is truly a distributed random process, you don't really need to map it. But I'm going to talk about the clinical dilemma. What does the literature say about AF mechanisms, where the sources do and don't exist, and from how many different angles can we look at that? A key area to me is AF electrograms are exceedingly difficult to interpret, because if we'd been able to do that, we would have probably solved this shortly after we solved atrial flutter. So how can we get confidence in interpreting electrograms and then future directions? So as Dave highlighted, there really hasn't been a lot of clarity on what to add to PVI. If we focus, of course, on persistent AF, we've got PVI from a study by Prash Sanders and others a few years ago, showing that the success rate in persistent for one procedure in gray, about 60, and everything else you add is not better and possibly lower. That includes, actually, if you extend this to look at something we're all pretty excited about, posterior wall ablation, the recent randomized trials were not showing a superiority. Now, the problem with this kind of study is that we've all had experiences where we do get success with a line, acute termination perhaps, and long-term success in other patients who might have failed a PVI. Many of us have had success with the other approaches. So why is that? Well, a simple explanation would be AF ablation is not one size fits all. And there isn't one lesion set you could apply to every patient unless you did everything, which is one approach. As Dave said, that would involve a lot of potential collateral damage. So the question, I think, really is something like this. You've got a lot of patients who are actually different, who are all labeled as persistent. Our goal is to identify, in this case, the greenies, who might respond to a line or a box or even driver ablation. Then the reddies, who might explain, I use that term because it's an Indian audience, who might respond to any other of the strategies and so on. Now, if you were going to try and identify a set of patients who'd respond to a lesion set, what would you use? So clinical data in my experience, is unlikely to tell you where to place your catheter. ECG hasn't helped immensely. I think a biomarker would help with understanding in general, but again, not guiding ablation. And so that gives you the idea that mapping is a way to personalize therapy if we're ever going to be able to do it. So this leads on to what Sanjay said. So it is actually a decade ago that I first presented the experience, building actually on decades of data from many groups, including Penn, including Ed Gerstenfeld's work. I'll come to work from Sanjay and many others. Sanjeev Saxena had done great work using ASI that predated this. But really, until that time, there wasn't an idea of what preferred regions in atrial fibrillation could be, although there was a heck of a lot of animal data across species. And that's now being extended to human that basically show that AF, though it's disorganized, can have a central driver. Now that could be a focus, or in this case, a rotational. And then we showed in our initial experience in 11 that you could actually identify these, and it looked something like this in those days, and that was validated by other groups. Now, the problem is, how did that work out in randomized trials? And the answer is not too good. This was the first randomized trial, really. 350 patients, 18 centers. I'm sure everybody saw this. Just before COVID, actually, Johannes Brackman presented this. My group wasn't involved. And as you can see, it was a wash. It was PVI versus PVI plus FIRM. Now, he also presented the sub-study, which didn't get as much attention, but I think this is important for learning. In both groups, the PVI and the PVI plus FIRM, there was a lot of crossover. In fact, it was about half of each had additional ablation. So it's perhaps not surprising that would narrow the gap and cause them to somewhat overlap. So again, it was presented that there were therefore 4 on-treatment groups. Now, the original PVI plus FIRM group was slated to give the study design 75% success. It exceeded that, actually, 77.7, single procedure with an adjudicated blinded review committee looking at ambulatory ECGs over the whole year. PVI actually exceeded its expected success and came in at 66. It was expected to come in at 55 to 60. But even those 2 groups alone actually hypothesis generating, there is a statistically significant difference. What Johannes and the other study investigators didn't anticipate would be the other groups, which diluted the p-value down to 0.09. Now, the second learning point here is that, in fact, just as Dave has shown and Atul demonstrated in STAR-AF 2, too much ablation in this, so adding caffeine lines, unfirm PVI, and other things actually unspecified, did bring the success down. So that certainly motivates for me the idea to try and do something more than PVI, which is not everything. So what does the literature say about mechanisms? Let's start with our experience. We've all had experiences a bit like this. Fibrillation like flutter may on occasion be terminated. So Thomas Lewis wrote, in the oracle by cold or pressure applied very locally. So taking the bottom left figure, this is from John Miller. How many of us have had this experience? We're ablating, doing a PVI by radio frequency, and at some point, the AF, which might have been going on for a long time, stops. So here's one of those cases from John, who is a former speaker, I think, at this meeting in previous years. And not only was the PV still not isolated, there's the potential, but it was actually non-inducible. It's an N of 1, but we've had experiences that are not infrequent. And how about this one? This is from Wendy Zhu in Colorado, published around 11 actually, that just touching this area of the catheter inadvertently kept on stopping persistent, going through an AT to stop, and then that would restart and it would happen again. So drivers, obviously, in the pulmonary vein started our field, and kudos to Bordeaux for recognizing that and giving us this option for our patients. Are they only in the pulmonary veins? So early work actually showed that if you look at AF after onset, and so each of these panels is time in seconds, 5, 10, 15, up to 30, and you look at the rates, the cycle length actually, then after the PV initiates, somewhere else actually takes over. And in each of these cases, the posterior wall, this is what was mapped for this study, was faster than the PVs that were looked at. And this is with this is done back in 2003, and the author's title was PV internal electrical activity does not contribute to the maintenance of AF. That was kind of a forward-looking statement, because although initiators are very important, what maintains AF? John Kalman recently published an extension of that. PV in 2018, pulmonary vein activity does not predict the outcome of catheter ablation of persistent AF. So if there's something else outside the vein, can we use it? So let's say it's there. Is it just something we can never get, or can we possibly get to it? What could it be? So in fact, studies for decades have shown that there are preferred regions. Now, they've used many names. Some people like the word driver, some people don't. Rotational activity, focus, repetitive activity. But Ed Gerstenfeld showed, actually one of the earliest papers in the field, 1992, that there were consistent vectors over time. Then you look at the same experiential time from my alma mater at Washington University. Jimmy Cox's group, surgical mapping, showed consistent circuits in many patients. And they wrote, unexpectedly, when fibrillation became sustained, the reentry stabilized to a small circuit. And in fact, Maze, as they initially wrote it, was designed as a bailout because they couldn't map everyone, and it would be areas where some of these circuits could be. Fast forward to the 2000s, many groups, including some work from Penn, Sanjay and Ed did some of this. This is from Al Waldo, a little bit more recent, stable circuits, not ablated. And then multiple frequencies from Michigan. Fast forward again, stable sites of block from Alessi's group, actually, that they said were not drivers, but they were stable again and again and again, suggesting some preferred region, and then stable entropy from Xian Chen's group. So how do we put that together? Are they drivers? Can we use that to map? That was the question that was posed. Can we use this? So the biggest question is, how do we interpret electrograms? So this was a pretty damning study of AF sources, basically saying they're rubbish. And this is from Miguel Valderrabano, who I respect immensely. So this was a study just published in JACC EP by Shiv Kumar's editorial team in 2021. And what they said was that, sure, they mapped and they moved. Most of these were CartoFind as some firm. Mapping algorithms were unable to detect pacing sites as true drivers and detected epiphenomena and did not identify true AF drivers. So a couple of points on that. I agree, it's tough. One point was ablation of a true driver would have to be ablated during AF. And so that wasn't done in the study, but of course, it's still a great study. Another thing, pacing is a problem for any mapping system because it's a spike that can, if it's very rapid, it's just going to be seen as a spike and it can mess up any algorithm. We've seen that. But the biggest question really is, fibrillatory electrograms are just really hard to interpret. If we say maps are uninterpretable, we can't see the electrograms, that is the point, actually. That it's because of that. How do we work this out? So this is an example of that. Are we the gold standard for mapping electrograms? This is work I did with Michel and Piaget's back in 2011. So here's a nice example of a spiral with a MAP, monophasic action potential catheter, which is a really great catheter. It's still available. I still use them I've done several this week. And here you've got upstrokes, which indicate local activity. And this was as close to spiral 9 to 19 as we could possibly make it. 9 to 19 is shown in red. So the question for the group is, which of these electrograms is local? Because if you can figure that out, we can put lines and contours and we can map AF without a system slowly. So I'm just going to put up a few boxes on this one. What would you call as local, the first or second? I'd probably say the first. Let's move to number 3 here. Would I call that local? I don't think so. I put it there to tease you. And at the end, I'd probably call that local. Now, if we take the MAP for the upstroke, let's see if we were right. And actually, this is similar to optical mapping, which looks at action potentials. So in fact, the local activation here is not the first one, which is this far field deflection. You wouldn't know, but it was the second one. How would this happen? Because bipolar electrograms are directional. So you don't know where it's coming from. In this case, the far field was actually just as big as the local. The second one here, I'm going to show you this one. It looks local. In fact, it was the far field. That was not local. And the final one, I wouldn't have even noticed it, but that was a local activation, obviously perpendicular to the bipole. So given that, we can't be the gold standard for marking AF electrograms because we're going to have false positives and negatives. So the second question, so we need some kind of tool, just like we have signal processing to filter the noise in our cell phone or to give us the internet in the first place, we need something. So Miguel, in the Twitter feed that Atul, myself, we joined in on, many techniques can detect re-entry, and I agree, actually. The problem is diagnosing mechanistically relevant ones, and I fully agree. So here's some data that I think you might find interesting. So this was a paper in Nature 3 years ago, looking to say, look, electrical signals could be called noise. Is it artifact? Is it real? Is it fake? Who knows? But what about if you looked at mechanical activation in the heart? Surely the mechanical contraction wouldn't lie. And so this is a study by Stefan Luther's group. They're extending it to the atrium. This was a VF study. And they looked simultaneously at speckle tracking echo and optical mapping of exactly the same region for electrical. And there's a rotor electrically and mechanically with an exceedingly high correlation in all cases. Now, atrial activity, mechanical in the atrium is obviously harder, but I know they're looking at it too. I can't say what they'll find. Now, optical mapping in humans has now been done by Vadim Fedorov's group, and they actually correlated this to firm, obviously a bit late, unfortunately, to help with support the argument. But in this study, also in JACC-EP, in fact, the areas identified by optical mapping were 80% concordant with firm and with other mapping systems, actually. So where does that leave us? Future directions. Well, obviously, there's still a lot of interest. And I would say whenever you look at a mapping study for AF ablation, you're basically trying to find a preferred region. Otherwise, you could argue you already have the anatomy, you wouldn't need to map. So on the left would be an older now era. As Dave said, anything more than 5 years old is old. So this is actually 3. This is also probably old, but it was a meta-analysis showing 70 to 80 in non-randomized trials. But as I've shown you, the on-treatment analysis of reaffirm was in that range. There are many exciting technologies to try and give clarity in what electrograms are. And these are a few. Richard Schilling's group has their own system. This is Acutus. I haven't used any of these actually. This is Chowdhury has this study radar. Other groups are looking at this too, just different names. So this is Natalia Trinova looking with the Hopkins group, Hugh Calkins and others, computational mapping based on the MRI, which Nasir is going to describe in detail. He pioneered that. Looking to see, does the MRI give you data you can computationally use to drive ablation? And in this case, they did, and they actually got termination sites predicted by the models. What were the models looking for? Drivers. So that was in their Nature Biomedical Engineering paper. AI is something we're looking at along with loads of groups. This was something Miguel Rodrigo was Young Investigator Finalist for last month at ACC. Further along than that is this work by Julian Seitz from France saying CAFE was a kind of subjective measure. Can we interpret electrograms better? And they use models to figure out what the shape should be and they got success. The models they used to figure out the shapes are actually driver models from Omer Berenfeld's group. So in summary, I think current ablation solutions for persistent AF need some help. Anatomical ablation is quick and easy, but if you want to tailor it for a patient, it's really hard to know which of any lesion set would work. And so how would we identify different AF types? To me, you have to map the AF. Of course, easier said than done. There are actually several approaches, and I think this is going to be an age of discovery, just like mapping the globe. I will say that in fact, many studies have shown glimmers of promise. Perhaps Atul Verma will show some success from, I know he's looking in STAR-AF 3, maybe others will show success. And obviously, everything has to be subjected to randomized trial, and that's where we are. So I'd like to thank, it's everything I've presented is massive teamwork. And I just want to, some of our group are actually, collaborated together with others in this meeting. So thank you very much.
Thank you, Sanjiv, for that excellent presentation and the material that you've shown. It's going to take the audience a little bit of time to wrap their heads around it, and I'm sure the questions are being formed, and we'll hopefully be able to address them after we finish with our third speaker, but that was terrific, and thanks. So we're going to move on to our third speaker for this morning. That is Dr. Nasir Marush. Dr. Marush is a professor of medicine and director of the arrhythmia program at Tulane. Prior to that, he was director of the arrhythmia program at Salt Lake City, Utah. Nasir and I, again, are contemporaries. We came up through our fellowships around the same time. I remember many avenues where he and I would present data from our work. And so it's been a friendship that's been long-standing. And Nasir has gone on to do some amazing work. We are all familiar with his most recent trial, Castle AF, that has really revolutionized our approach to AF management in heart failure patients. But preceding that, one of the things that he really brought to the attention of the EP community was the presence of fibrosis in AF patients, which really was a determinant of their behavior in terms of the response to ablation, but several other things. And so this work that he did, the DCAF study, which kind of made us all sit up and realize there was more to it than just what we were seeing on the surface. And now he's in the process of doing the part 2 of that trial, where targeting these locations that manifest fibrosis, whether that can enhance success. So I'm so glad that he was able to find time from his very busy schedule to join us this morning to talk about his experience on utilizing advanced imaging to improve ablation success. So Nasir, welcome, and I look forward to your presentation. I don't know if you need to unmute yourself.
Can you see my slides? Can you see my slides, guys?
Yeah, your slides are visible.
Yes.
Sorry. Thank you for the great invitation, by the way. I really, it's an honor to be here. I heard from Sanjiv Narayan a lot about these sessions you're putting together, and I was excited to see that I can be part of this and share. And obviously putting me after Callans and Narayan, it's I'm not sure you love me that much already. I think that's more a challenge, but I'll try. We worked a lot on myopathy, and I think what advanced imaging over the last 14 years now allow us to realize is there is more into treating the atrium than just burning the tissue. And you've seen some great examples from Dave and from Sanjiv already that we need to be more targeted, and we're still struggling finding solutions around managing patients with persistent AFib, and we're looking for next trial. I want to go back to the myopathy question and concept and why we with advanced imaging has been very helpful in understanding more than just standard of care and treatment, but rather the physiology and what's going on in the atrium. If you start with how we image atrium fibrotic changes, it's an MRI scan. I think by now, I looked it up Friday morning, there is around 280 papers on this subject published from multiple labs, looking at atrial fibrosis, correlating it to outcome, progression, strokes, and beyond. So it depends who have access, as Dave and his team and Dr. Dixon in Penn, for example, they have a great lab with advanced imaging. They can look at this images, and hopefully everybody else in the world will able to do so. But to summarize, we do a sequence, and then we try to process this image. There's a couple of tools available today in the industry that can help you doing so. And this is the end image that I see in my lab when I treat my patient or my clinic, because now we're using it routinely for triaging patient options. This is a patient you can tell there's no appendage because of the closure device, and we try to monitor this patient after. Myopathy is a part of our treatment today, and this is what we look at. This is important for you to know that we're looking at this kind of changes in the atrium. This is an open heart study that Dr. McGann published with Dr. Amit Patel, cardiac surgeon, where they looked at the correlation between these changes we see in MR and the real tissue. And you can tell they could correlate this successfully to extensive amount of fibrosis in these areas where they did the biopsies. And this is a patient with tiny changes, have no history of AFib back then that they included in that study. And the reason why I'm showing this, because this is the type of patients we deal with in our labs. When you walk to your lab tomorrow, you have a variation of hearts and atria you deal with, from little fibrotic changes to extensive. And for example, this is a marathon runner that came to see me, 51-year-old female. An 82-year-old man was skiing and had AFib come to see us. So it's very hard to assign it to certain comorbidities so far if you look at the data, and others has been confirming this. And that's a patient I'm brought with me today, 77-year-old woman, 10 years of AFib, LV dysfunction, EF of 40%. What do you do next for her? And you look at atrium, she's a little myopathy, maybe a little bit an anterior wall, but I'll be encouraged to take this patient lab and ablate her despite the persistency in her AFib and the long duration of AFib, long-standing AFib. And this is a 3-year-old of paroxysmal AFib patient, another extreme, who comes with extensive amount of myopathy. And the data continue to show that if you look at this patient's atrium with green and white myopathy, myopotic tissue, they're very hard to treat in terms of curing them or suppressing AFib, and also outcome data has been confirming that. And this is very important for us as well as an ablationist, because we grew up, what Dave Callans back then taught us when we were, it's coming fellow, he doesn't look that old, by the way, he looked younger than me if you look at him today. But Dave taught us back then, when you ablate AVNRT or a flutter, you terminate it, you stop, you go home. That's what we grew up as 1999, 2000 EPs fellows. AFib changed that, right? We ablating AFib and we're waiting for something, and we starting to accept that AFib is not an endpoint as a recurrence only, rather than the burden. You can have little AFib and little that. And the reason why, and I think that's important, we continue to neglect that the myopathy process, it's dynamic. It continued to grow. And this is 2 examples I brought from me today. This is a patient who within 2 years have some increase in the volume, not massive, of the myopathy. You can tell between these 2 images. And this is another patient within 3 months. We imaged them multiple times to confirm, and you can tell if progression is ongoing. So that's something we have to correct for, and we publish on this. This is Dr. Kherkekian, who looked at the recurrences after ablation. By the way, we look at red, when you image the patients, this image processing software gives you the ablation lesions in red based on certain thresholds and intensity. And green is initial fibrosis and the new fibrosis, as we call it, myopathy, and the initial non-ablation myopathy. But you can tell there's people have a new myopathy after ablation with recovery of lesions, and there's people have continued new concepts, and new atrium. And this patient is very, very solid. So looking at those, and that's an important, because this new fibrosis has been shown to be an important predictor for outcome. And you ask yourself why patient continue to coming back despite good lines and good lesions, and why we are 50% success or 55 or 60. That's an important reason why the new myopathy that we have to target for and correct for and account for. Also, myopathy is important when we treat this patient. We are not treating just a piece of tissue in the left atrium. This is I'm sorry for the quality of the slide that published by McGann as well, but we correlated this to the amount of fibrosis, stage 4 more than 40%, 20-30% atrial fibrosis or myopathy, and 10 to 20. And you can tell there's more persistent AFib as you increase, but still this is across the board. You can see any kind of atrial fibrillation despite the extensive myopathy. You still have 30% of patient proximal AFib within stage 4 myopathy. DCAF1 taught us a lot. Dave was part of it, and Frank at Penn, and we looked at the outcome, after ablation. So we let the people ablate their patients in DCAF1, and we published a while ago in 2014. And the bottom line is the more myopathy the patient had, the higher chance of having recurrent atrial fibrillation at follow-up. Independent approaches and independent of lines. And then what also showed that the atrial myopathy itself, especially if you cross the line 20% of atrial myopathy, and this is a work of 2011 by Dr. Dakaret, the higher chance of people presenting with stroke or stroking. We continue to see this in multiple other studies, not only from in the US, but also in Europe, and in Denmark has been represented this recently. And if you look at the myopathy in correlation to echocontrast and spontaneous echocontrast and left atrial appendage thrombus formation, Akum, who's now at University of Washington, showed this correlation to myopathy. The more myopathy you have, the higher chance. It's kind of confirmation that this myopathy, if a powerful predictor for clots and spontaneous contrast, with the impressive C statistics, more than 0.80, which is an impressive number in predictive models for strokes. Also been shown not only by us back then in Utah, but others in the world, Bierkowski and his group in Germany, the very well correlation between LV dysfunction, and I think Saman worked on this a lot at Penn, correlation between LV dysfunction and the myopathy and the atrial myopathy. And what we showed in this paper was very important, that the outcome of the procedure, success of terminating, suppressing atrial fibrillation, was really not the predictor of improvement LV dysfunction, and you see in this slide. Rather, the amount of myopathy was a very good predictor for improving the LV function. So more and more data, as we anyway looked at it, this myopathy is important. King looked at 1,200 patients prospectively in a prospective database, and he looked at and showed that the higher the myopathy you have, the higher chance of stroke in the patient population presenting for management of atrial fibrillation. Also, recent late breaker from IHRS, I think it's being published as well in Heart. I think it came out or not yet. I'm not sure, but I think it's Akuma is being in the process of publishing. But they showed that the more even ESUS, unknown origin, strokes unknown origins correlate very well with atrial myopathy. And as you know, we learned a lot from Crystal AF that AFib is there. If you look further, you'll find it. But the myopathy seems to be as important. You see the amount of myopathy seems to be similar to patient with atrial fibrillation in patient with ESUS. So this is an important factor that we cannot neglect, that we're dealing with every day when we go to the EP lab. So how to treat it, how to deal with it, a lot of ways. You see a lot of studies going on, and this is what we learned from DCAF-1. So DCAF-1 has been published, as I said. We learned that standardizing approaches, this is multiple labs, as you've seen from the slide I showed you, very experienced centers for AFib management. And you can tell the lesion formation back then, and I go back what Dave Callans said, technology changed. DCAF-1, we were ablating in 2011 and 2012. We did have different tools, and duration of ablation and so on was different. But nevertheless, this is what we saw. We saw that the lesion formations, PA views on 64 patients, and lesion formation is lacking. It's not ideal as the operator wanted to put it together. And you try to correct this to look at outcomes as well. And we looked at residual fibrosis in this study, and we realized the more residual, non-ablated, non-targeted areas by lesions, you find the higher chance of recurrence, and as seen here. So you need to target more fibrosis. That's what we thought, and that's why we planned the DCAF-2 study I want to talk about in a minute. We also, LV dysfunction, come back. I don't want to repeat this slide, but I want to show that Kirsten in Germany showed the similar data here, more myopathy, higher chance of recurrence. So DCAF-2 that we will hopefully present this year at ESC, we finished recruitment. The last patient follow-up was in February. We are analyzing the data as we go. Hopefully we get the final data, and we sit with steering committee with Dave and the team at Penn, and everybody on the steering committee to discuss the data in end of June. But this is the sites, 52 sites worldwide. We have 840 patients, which we randomize them for. Group 1 will be PVI only, as is seen here. So the operator, by the way, will not see this image. They will see only a shell. And we gave them to do standard of care for persistent AFib patients. By the way, persistent AFib population, they do PVI only, RF or cryo. And group 2 will target fibrosis, will use a fibrosis as a target. So that's the ideal solution. A protocol allowed them to encircle or ablate fibrosis. But we've seen it all because of different approaches, as you know, from study F trials, from Verma and others, and the Rotter's approaches and so on. But people were supposed to do this, and you've seen, and there is a control. We have a group which is controlling for outcomes because we have per treatment analysis, we have per protocol analysis, and what we looked at, part of the endpoints, is that patient did the operator do their lesion sets? And this is an example, right? This is a patient, this is an operator supposed to ablate fibrosis and myopathy, and you can tell how the approaches vary between this operator and this operator. And obviously, and as another example, a patient just does the box, so isolating this, and it's a box approach for PVI. So this is interesting because this is a reality. This is what's going on, as Sanjiv said, in real life in ablating AFib. We're looking at lesion formation in DCAF2. We'll learn a lot because every patient have 3 months follow-up MRI. So you can amount for 800 MRI, 840 MRI scans that we're going to look at controlling as treatment analysis. For example, in this here, we have a PVI patient. Was the lesions inserted and delivered as supposed to be? So we're going to look at this. Also, we're looking at something called, which is defined in the protocol originally, it's called the operator residual. Did the operator cover? So we're collecting every single CARTO, ESI, or arrhythmia point. These are the system used in this trial. And by the way, we have 170 cryo balloons in the trial as well, without maps, without points like this here. But why this is important, because is it operator redelivered initially as per protocol analysis, and then we're looking at residual fibrosis analysis as well, and the 3-month scarring and the covering residual fibrosis and so on. So we will learn a lot, and that's another example how this is operator residual, where the operator tried to cover fibrosis, he left behind some. So we have a whole team, unblinded core lab, in fact, looking at this data. So we have 5 people in the core lab outside Utah and Tulane, looking at these data, analyzing them and grading them, how much of fibrosis, look at outcomes. Did we do the job or not? And that's important because we have the lesions we can look at. Encircling PVI, we're going to learn from this a lot, as you can tell. Is this enough? Are we encircling enough myopathy data or not? And this is a beautiful example how good PVIs are those. In this here, you can tell this one here, good encircling. This one here, you can tell this one is more RF, more outside. This looks like a balloon. But we're going to learn a lot from the lesion formation in DCAF2, which is, I can't wait to start getting data and sharing it with you. So this is summarizing how what's imaging guided approach will help us understand, because DCAF2 is not only taking this as a Bayesian predictor of outcome and learning what we've seen in DCAF1, but also looking at why people recur, what type of fibrosis is important, are we covering it good enough? Are we forming lesions? Are we forming, I repeat that, are we forming lesions? Are we ablating? Yes. Are we forming lesions on top of myopathy? Should we do something else? Should we neglect that and avoid this patient ablate around the myopathy, or go back to Sanjiv and say, which part of the myopathy is important based on rotor anchoring? I don't know. We'll learn all this. Residual fibrosis. What does it mean? Operator residual are delivering the lesion. So delivering lesion is one thing, forming lesion is something else. And I think DCAF2 will be the first study to show us that, because we're going to correct, that's what we're lacking. For example, STAR-AF2, right? I wish I had this all information from the CAFE data and the line groups to know that they do lesions and not. So here we're going to be able to share it and discuss, and hopefully all of us learn from that. Thank you, everybody. And TulaneTriad.com, you can look at our team who did this work, because it's a website that we share with everybody. And there's 12 protocols going on now with this myopathy studies. I encourage you, anywhere you are in the world, to please sign up, and we'd love to share with you your protocols and ideas as we go forward. And again, Sanjiv, thank you for inviting me to this great gathering.
That was terrific, Nasir. Thank you very much for sharing some of the data that's still in the process of getting reported. It's our unique insight through what you shared with us. So I think what we're going to do now is open up the session for questions and answers that the audience and the panel may have for our first 3 speakers. I'm going to invite my co-chair, Dr. Center, to join me in getting the questions addressed. And while Dr. Center lines himself up, Nasir, there have been a couple of questions that have come through for your talk. I think you've convinced the audience that the scar homogenization, if that's the term to use, has value. And in your own opinion, having kind of, seen AF evolve from the early 2000s to where we are now. Are you convinced that that's really the way to go? Or, for example, let's say if somebody has scar in a discrete location and the veins, would you isolate the veins and do the scar? Do you feel that the scar is really all there is to it?
Can we wait for DCAF2 to tell the story?
Well, we need your insights. I mean, we'll obviously have the data and we'll all read your studies, but we want to hear this.
That's a Dave Callans question right there. Yes, no, there's a group. If you look at the scar, and that's something we need to start working on, or we're doing this as we speak. The whole work in image processing now is we're trying to differentiate scar. There's 2 different or 3 different kind of ways scar presents itself, and that's what I'm learning to start correcting for. I really would like, obviously DCAF2, as you know, with DCAF1, we realize whatever you do with the advanced fibrosis, you don't, that's why the study had almost 1,000 patients to correct for those. And the early stages, PVI, right? But in the middle, how we deal with fibrosis, and there's 2, you can't say it, but what I learned with my career, with my 12 years doing this, is not every myopathy is the same. And the way it presents itself and the location of the myopathy is becoming very crucial in treating this. But there's 2 reasons why this is becoming more and more important. One is triaging patient, understanding the strategy going in. For example, now what do you do with the appendage area? What do you do with the, is it posterior wall, is anterior wall locations? Are they important? Are they not? They tend up to be, in my experience, less and less crucial in ablating them in terms of outcome, because now we're looking at stiffness of the atrium. We're looking at the functionality of the atrium after ablation. Is it useful to do so? Not only the AFib recurrence. And I'm realizing is like anything else, more doesn't mean better for everybody, but selected patient population is my own experience. You have to be selective like anything else, but more homogenization. And you've seen there's 2 studies that have been presented already, right? One is voltage guided and one is fibrosis guided for paroxysmal AFib from Spain, and not feel a difference expect with subgroup of patients that they could target. So that's, I think what I learned is not every fibrosis is the same, not every myopathy is the same. Unfortunately, the more myopathy in terms of outcomes, strokes, and heart failure means a lot. In terms of predictive model, you need to correct and be aware of it. But in terms of treating and ablating, you really have to personalize the fibrosis you're dealing with. And that's what we're working on in imaging those, some imaging those into the myocardial layers within the atrium.
Since we have a few questions, I think some of them are for Dr. Callans. We'll first go with the audience questions. Is it okay,
Yeah, please. Yes, absolutely.
I think we should take care of the audience first, and then we start asking the questions. Now, the first question, probably first couple of questions would be to Dr. Callans. Now, one is, how many times do you manage to isolate only 3 PVIs is the question. And the second question, can you elaborate a strategy for non-PVI triggers? How do you approach it for ablation?
Thank you, Dr. Santhar. With current technologies, and we throw in some cheats in the Penn Lab that we feel are very important, including we do all of our procedures under general anesthesia with jet ventilation, so very small tidal volume. It really adds quite a bit to catheter stability. With the catheters that are available right now, even without getting fancy with pulse field ablation and things like that, first pass isolation is the rule. I don't think we ever leave the lab without all PVs isolated, at least acutely. So that, I think, is something that technology is really solved for us. And what I meant, thank you for picking it up, Sanjiv, by this, papers from 5 years ago being old, if we have technology that can actually accomplish the strategies, then hypotheses can go forward. We didn't know before about whether the hypotheses were wrong or whether we just weren't able to accomplish them. So PVI is something that is uniformly obtainable now. For the non-PV trigger part, this is very difficult, and it takes some loving care. So obviously when you have a non-PV trigger, it's one beat and then off to the races. So we really map iteratively. We have lots of catheters in the heart, and we've used, kind of gotten used to compartmentalizing the atria by the background catheters that are there. And then it's like the child's game, you're getting hotter, you're getting colder. You have to keep getting at these, repetitively until you narrow down into anatomic structures that are responsible for them. That's helpful that a lot of times they come from the same anatomic structures. So once you correlate between, right or left atrium, the anatomy really kind of dictates where the hotspots usually are, and that helps us sort this out. But it is difficult and very time consuming, but important.
Dave, do you want to speak a little bit about the stimulation protocol that we use?
Oh, sure. So it's pretty intensive. So we would, usually it's done after PVI these days for getting the procedures done. We would look for non-PV triggers with high dose isoproterenol, up to 20 mics per minute. And I think that's really important to kind of stay there for a while. At each stage, we do that gradually because a lot of times the hypotension that results on anesthetized patients with isoproterenol has to be dealt with by the anesthesiologist at each step. But the dwell time is also very important. And often these triggers come out even after the cessation of giving high dose isoprel, after that cool down period. So we would do that. We would also do burst pacing with residual isoproterenol effect to bring out flutters or to intentionally induce atrial fibrillation with cardioversion on residual isoproterenol. So all of those steps kind of bring out triggers in different ways, but however they come out, we think they're important to track down.
Thank you. Thank you. Dr. Marush, a question from my side, because we have been doing some work on rheumatic atrial fibrillation. We have done histopathological studies on rheumatic atrial fibrillation. Now we are doing some work on, I think that's the worst pathology that you can have for atrial fibrillation. I think all of you will agree. We have been trying to do some MRIs, but we have been having a lot of difficulty with identifying these scars, as you say, or fibrosis. Apparently, we have been trying to get some, software, which is very difficult for us to get. Nevertheless, have you looked at what happens in the right atrium? Because most of your work is on the left atrium. What are the, the images that you get from the right atrium? And because there are some non-PV triggers from the right atrium, right? So can you enlighten us about that, please?
Thank you for the question. I think you have two experts here with me as well, Sanjay and Dave. I mean, they initiated a program a couple of years ago for cardiac MRI advanced imaging in EP with Sanjiv Narayan. Let me answer your first question. That's a full disclosure, and I have to admit, this has been a challenge for us too. Getting cardiac MRI up and running. I just moved here 2 years ago to Tulane from Utah, and I was living in an MRI haven before that. Unfortunately, that haven now has been dismantled to go to other places like Hopkins and so on. But we had a hard time building this here. Coming to a new place, I realized how hard to get cardiac MRI up and running. It wasn't easy. We finally got our 2 MRI scanners, one for research dedicated, and it's down to the sequence and your team. You need what I realized the key for that, and I think Dave and I talked about this a lot before Saman came over. You need a partner in cardiac imaging. You need a person who really believes and can work with you on a cardiac MRI scanner. Everything else is now doable, and every single site, and we have 52 sites in DCAF2, we have only 8% images drop out or lost images in the whole study. Imagine for a bad quality MR or technician did the wrong thing because the training and all these sites could be trained on a sequence like the ARVD sequence or ischemia sequence. It's straightforward now, and every single partner in MRI have that sequence now. And processing is image processing. It downloads software for $5,000, whatever it is, and you can do it. And you have a couple of those available now. I think the key, what I learned, it took me some time, took me moving to Tulane to learn, you need a cardiac MR partner. Otherwise, even you can be an EP who driving this and believe in this, it doesn't work unless you have a cardiac MR partner. And you can tell the Sanjiv Narayan example in Stanford is the same. Finally, it's up and running because have somebody to work with them. And that's something you have to figure out, the importance. The data is continually coming out left and right. Right atrium, we published 2 papers on this. Dr. Akum looked at the patients with right and left for predictive. We looked at patients with inappropriate sinus tachybrady syndrome. And we published this and correlated this to the amount of myopathy in the right atrium. We segment those and we process those in every image, but I tell you, the amount of myopathy we see is very, very little unless it's very advanced in terms of predictive models. We never sat and mapped those like we do with the left atrium all the time, but in terms of, we have 2 papers now showing that the right atrium follows the left atrium, but the patients with tachybrady syndrome, the patients who need pacemaker seems to have more sinus node area and myopathy that more than others. And this has been published, I think, around 8 years ago in JCE. There's another paper followed that with the right atrium with Dr. Bisbal, who was with us in so we dropped that. It's still part of the image. If you wanted the image, I showed it you in the patient example, my presentation, the right and the left. I showed you both, but usually the right follows the left in terms of whole myopathy. We don't ablate as much there. We don't do the non-pulmonary ventricles like others do, but if you do, you have the image with the processing software and they give it to you.
Is the processing software restricted to a certain vendor like the Philips or Siemens, or is it the same for all everything, whether it's GE, Philips, or Siemens? Can you enlighten us, please?
That's what DCAF2 showed. Yeah, DCAF2 was 10 out of 52 sites. There were 38 Siemens and 7 Philips, and the rest are GE. And they all worked great with that. And then you should, I think there's a paper coming out as well with the initial fibrosis imaging data from DCAF2 to show you the experience with all 4. But yes, it's been unified. And every single vendor, you ask them specifically for the atrial myopathy imaging from DCAF2, they can help you with that.
So there are...
I think we probably should address a question to Dr. Narayan and then move on to our next panel of speakers, and we can have more extended discussion for the unanswered questions at the end again. So
Sanjiv, now considering that some of the areas of rotors are areas of functional sort of blocks rather than anatomical blocks, is it going to make a difference whether we anatomically delineate the fibrotic areas from the non-fibrotic areas? Is it going to be that we are going to use the anatomical maps to ablate or use the electrophysiological maps to ablate?
Thanks, JP. I think that's a fantastic question. The 2 things, the electrical activity follows the anatomy to some extent, but not always. If we knew the anatomical distributions that would cause a specific electrophysiological pattern like we do with typical flutter, we could target that like we do with typical flutter. I think DCAF2 will help with that. I'm a firm believer in fibrosis. We're, as Nasir said, are just getting our MRI protocol up and running at Stanford with an MRI champion in radiology at last. But I think if you look at distributions in the literature, there are many fibrotic distributions that may not be important for driving activity by whatever mechanism, either wave break, anchoring a driver, being something that near the pulmonary veins. That's something that I think we have to work on together. that's the focus of Natalia Trajanova's work, that in a computational model, can she figure out which bits of fibrosis are key and which are not? And we don't yet know the answer. Great question.
Okay, I think we'll move on to the next sort of talk. So can I invite the next speaker? Will be Dr. Atul Verma. Will be speaking on ablating paroxysmal and persistent AF, optimizing strategy to enhance success, please.
Let me just take a moment to introduce Atul, not that he needs any introduction, but you know, you've heard him being mentioned throughout the first panel. And to me, STAR AF2, we were just the biggest supporters of your findings at Penn, because it's been our observation within our own experience that additional substrate modification beyond pulmonary vein isolation does not seem to work. But I know that in talking with you, that while the trial that you published shows that additional substrate modification may not be the answer, that doesn't necessarily equate into PVI being the solution for everything. And I know you're doing some additional studies, so Atul, we are delighted that you're here with us, and we'd love to kind of have you address this topic. Is one strategy good? Two strategies have to be optimized based on the AF, and especially in light of some of the work that Nasir has shown us and Sanjiv's observation. So welcome, and thank you for joining us.
Yeah, thank you very much, Sanjay. And I have always been huge fans of the work that you do at Penn, and it's a pleasure, frankly, to be participating in this very esteemed group. So thank you very much for inviting me and allowing me to be a part of this. So today, the topic I was given was to speak about ablation of both paroxysmal and persistent AF, with a focus more so on persistent AF and some of the work that we have done. These are my disclosures, if I can get my slides to advance. There we go. So this is a particularly favorite study of mine, in part because it's Canadian, in part because it was authored by my good friend Jason Andrade. But I think when we talk about contemporary data, and we've been talking about the importance of data being dated, this is about as contemporary as data gets for ablation of paroxysmal atrial fibrillation, because the groups compared were contact force guided RF ablation with modern day catheters and modern day cryoballoons, 28 millimeters. So this is about as contemporary as it gets. And for paroxysmal atrial fibrillation, a PVI only approach, they found it doesn't matter what technology you use, but you're going to get about a 50% freedom from any atrial arrhythmia after a single ablation procedure. However, I think what was very interesting about the study is that all of the patients received implantable loop recorders. So although the Kaplan-Meier curves suggested a somewhat depressing story about the outcomes of atrial fibrillation, the ILR data actually suggested a very different story, where patients experienced a 99.9% reduction in their AF burden. And I don't think there's any patient who would not undergo ablation if you told them that there was a 99% reduction in their AF ablation that they could experience after the procedure. So I think that's all I have to say about paroxysmal AF. PVI, wide antral PVI works, and it works quite well. And our success rates are probably inadequately measured by the time to first recurrence model. Speaking of the limited time to first recurrence model, here's my data from STAR-AF, which has been shown on numerous occasions throughout this morning, where we basically showed that for persistent atrial fibrillation, PVI really was just as good as PVI added to other modalities. And I think it's important to recognize that this did not necessarily prove that any further strategy was not going to work and that PVI alone was best. It just showed that fractionated electrograms and empiric linear ablation did not seem to be the solutions, at least at that time. Now, granted, there were technological limitations because we weren't using contact force catheters. This was not contemporary technology. But having said that, I also want to show you this data from STAR-AF2, which is the burden analysis. And we just published this recently in JAMA Open. And although we did not have implantable loop recorders, we had more than 50,000 AF TTM transmissions from the patients. And we measured AF burden using a time in therapeutic range type model that you would use for INRs, where we took serial recordings over time and estimated the burden. And you can see here that almost 80% or more of the patients had an AF burden of 10% or less post-ablation. And all of these patients had really persistent or long-standing persistent AF beforehand. And this is a pooled analysis from all three arms. So again, going back to Jason's work, this shows that even with our limited abilities back then, we were still achieving incredible improvements for most of our patients. Now, would contemporary technology with contact force have significantly altered the outcome? And that's where we did the TOUCH-AF trial, where we used more contemporary contact force guided three-dimensional mapping guided wide antral ablation. And we did a minimalist strategy of wide antral ablation. We did allow a roof line if people wanted to add it, but most people just got wide antral isolation. And for these 128 persistent AF patients, you can see that the one procedure success rate improved from STAR-AF2 times from about 50% to 70% using the same time to recurrence limited model. So it would seem that contemporary technology does have a role to play in improving outcomes. Interestingly, though, when we looked at the redo ablation success rates, we have historically been used to seeing a first procedure success rate of, let's say, about 50%. And then when we take the patients back for a second procedure, it improves to about 80%. So we tell patients, well, if we go from 1 to 2 procedures, we can improve your outcome by about 30%. However, what was interesting in TOUCH-AF is that the first procedure success rate was about 70%. But after 2 procedures, it only increased to about 77%, which implies that when we keep repeating wide antral PV isolation, and even if we do it really, really well, and even if we take more than 1 procedure to do it, we don't seem to buy a lot of extra success rate because we didn't allow any other additional ablation during the redo procedure. We only allowed another wide antral PV isolation. So there seems to be a plateau effect of how good you can get with wide antral PV isolation. So what was interesting is that STAR-AF2, kind of divided the EP community into 2 groups. There was one group that kind of went off and said, we're only going to do PV isolation, and let's look for technologies that help us do that better. And then there was another group that said, well, you know what, STAR-AF2 said fractionation and linear ablation didn't work, so let's find the real solution. And so there was kind of this whole birth of new approaches to persistent atrial fibrillation, including Sanjiv's work on rotational and focal activation, scar-based mapping, which Nasir talked about elegantly, new subsets of CAFE, non-PV triggers, which the Penn group pioneered from the very beginning, and then, of course, posterior wall isolation. And what was interesting is that, some 4 years after STAR-AF2, the Japanese did the EARNEST PVI trial, which eventually got published in the European Heart Journal. And what they did is they kind of recreated STAR-AF2 a little bit, where they had a PVI alone group and a PVI plus group where they allowed linear and/or cafe ablation and/or both. And they actually sought out to demonstrate non-inferiority. But what was interesting is that the PVI plus group actually had a significantly better outcome compared to PVI alone, and they were not actually able to demonstrate non-inferiority. So you can see there that the p-value was not significant for non-inferiority, meaning that the two groups were actually different from one another. So it's kind of a bit of a reverse of what we're used to dealing with in clinical trials, but that's mathematically what it means. So let's go through a quick trip through all of these different strategies that we can look at. And I'm not going to spend too much time on simultaneous mapping during atrial fibrillation because, of course, Sanjiv talked about that. And Sanjiv talked about what appeared to be the disappointing results of the REAFFIRM trial. Having said that, it was a bit of an unclean trial because you kind of had PVI plus FIRM plus whatever you wanted to do versus PVI plus whatever you wanted to do. And that didn't make for great control groups for a clinical trial. But as he showed you, and I'm not going to belabor this point, the group that had PVI plus FIRM alone seemed to actually do better. And the patients who got a lot of extra ablation actually seemed to do worse. Well, what about using electroanatomical mapping to define scar regions? So Nasir talked a lot about how to use MRI for these purposes, but there have been other groups that have been exploring whether or not electroanatomical maps could be used for this purpose. My friend Pablo Nair in Canada is currently doing the so-called COAST-AF trial where they're comparing a PVI plus BIFA type approach to PVI alone, and that trial is well underway. The problem, of course, is we don't have very good definitions for what constitutes scar on electroanatomical mapping. Is it less than 0.5 millivolts? Is it less than 0.25? Is it less than 0.1? I would love to hear Nasir's take on this and how good the correlation is between electroanatomical mapping and MRI. But in any case, the Chinese already did this trial where they compared a study population of persistent AF, and they compared the so-called BIFA type approach, which they called the stable SR approach of mapping, compared to the so-called stepwise approach used by the Bordeaux group. And when they compared these two approaches, they found that both of them pretty much gave you the same result, which was about 70% success. And that's what I showed you getting PVI alone earlier in this talk. So we seem to be locked in this 70% kind of level. Sanjiv mentioned Julian Seitz's work on spatiotemporal dispersion of CAFE, and what makes their definition of CAFE different from the older definition is that they're really looking for activation patterns within the areas of fractionation. And those activation patterns in that waterfall type orientation that I'm showing with these arrows here are basically reminiscent of the rotational type activation patterns that you might have expected, let's say from Topira or other types of mapping systems. So they did a very elegant study where they compared, a spatiotemporal CAFE ablation approach versus, their usual type of approach. They didn't necessarily isolate the pulmonary veins, so that you have to keep that in mind. But having said that, even with their approach, more than 50% of the patients were still having recurrences of atrial arrhythmia, and also a huge proportion of those patients remained on antiarrhythmic drugs. So while I thought this study was very interesting from a mechanistic point of view, the overall final results were not all that promising. Now they've gone on to now look at a more artificial intelligence approach, but that AI approach, Volta Medical, is still very much based on this same spatiotemporal dispersion approach. We've talked a lot about the posterior wall and the fact that previous studies did not necessarily show a benefit to posterior wall isolation, although certainly in this meta-analysis there appeared to be a benefit. And depending upon how much of a fan of the CONVERGE trial you are, the CONVERGE trial, which was a hybrid AF ablation approach, certainly seemed to suggest that adding isolation of the posterior wall benefited the outcome of patients. And if you, of course, go back to Jimmy Cox's Cox-Maze procedure, he was describing a long time ago that the posterior wall was a very important part of this approach. Let me return for a moment to dynamic mapping during atrial fibrillation, because since the days of Topira, where Sanjiv was very much a pioneer in this field, there have been a lot of iterative approaches, and Sanjiv showed you some of them, like radar and other types of algorithms, which have been trying to identify these drivers. And, you know, I've had the privilege now of being able to use multiple of these types of technologies, whether it be the Acutus mapping system, where I'm showing you some examples of these drivers as identified by Acutus, whether it be the Cardio Insight system, or whether it be, for example, the CardoFinder system. And I think some of the iterative approaches that these different systems have improved upon from sort of the early days is that, number one, there's perhaps an easier way to interpret these maps in 3 dimensions, which was lacking with Topira, where you had to look at it on a 2-dimensional view and then somehow translate that to the 3rd dimension, which was tricky. Secondly, I think there's more clarity now in the types of electrograms and being able to visualize the electrograms at the point of where these interest markers are placed, so that the operator has the ability to look at those electrograms and either convince themselves or unconvince themselves that this site is actually important or unimportant. And I think the QS pattern of unipolar electrograms, the serial waterfall pattern of a rotational activation is important to show an electrophysiologist to say, listen, there is something here in your basic 101 electrophysiology interpretation of electrograms that may convince you that there's something going on here. And then, you know, we can get into really fancy stuff. This stuff looks like space age mapping from Ablation, you know, and I think, you know, using electrocardiographic flow mapping, which is also a mathematical construct with multiple electrode baskets, but also looking at the electrograms, you can actually try and differentiate active versus passive phenomena. So for example, here is a focal activation, which seems to be driving atrial fibrillation. But right next to that focal activation, you have this spiral or kind of rotational activation, which in this case actually appears to be an epiphenomenon or a bystander. So, you know, if we only ablated this rotational, we would actually not be addressing the atrial fibrillation in this patient. And what we actually have to do is move our ablation catheter over in order to actually get the focal activation. And as it turns out in this example, even after elimination of the focus, that rotational activation remained an epiphenomenon, which continued even after ablation of the key phenomenon. So, you know, having now used multiple of these technologies, what I have noticed is that there are actually more similarities then there are differences amongst these technologies, which has been, I think, important for me and has been reassuring, because if each technology was showing completely different things in completely different areas, then I think it would be very hard to believe in this approach. But in fact, it does seem that these technologies are showing more similarities than differences. There does seem to be a hierarchy of phenomena to ablate, perhaps starting with the pulmonary veins, moving to focal activations, and then perhaps also rotational activations. And we also have to understand that there is an interplay between this dynamic physiology and anatomy. And I think Sanjiv showed that in the example of the Nature paper, where the anatomical aspects of the ventricle were determining the electrophysiologic conduction of the ventricle. And similarly, I think we learned that from a lot of Nasir's work as well. So we are in fact launching towards STAR-AF3. The trial is in the process of opening. You know, it was wonderful trying to get a clinical trial off and running during a once in a lifetime international pandemic. Which was a lot of fun, but now maybe there is light at the end of the tunnel. We have sites in Canada that are starting to activate. We anticipate having about 45 centers worldwide to compare wide antral PVI, PVI plus posterior wall isolation, and PVI plus elimination of drivers in these three arms for persistent atrial fibrillation. And we're actually selecting a sicker persistent population. So we are excluding early persistence, and we are including long-standing persistent all the way up to 3 years. So we actually are hoping to tread new ground by not sticking to the traditional persistent AF patient populations. And with that, I'll stop there. And, you know, I think I'm happy to either take questions now or later on, depending on how the chairs would like to do it. Thank you very much.
That was great, Atul. Thank you. I think we'll defer the questions till the end to kind of, you know, have multiple questions in the discussion portion. But thank you for the very insightful commentary. I'm going to move on to our next speaker, Dr. Rajiv Patak. Rajiv is a dear friend and an ex-Penn trainee. He was here with us a few years back, and after finishing his training, he went on to become the director of the National University in Canberra, where he's really, you know, up and running and is now doing some amazing work. But even when he came to us at Penn, he was already an established investigator, and this work that he did on addressing risk factors in patients with atrial fibrillation, a series of JACC publications, Arrest AF, Legacy, Cardio Fit, really made us all, you know, pay attention to this very important aspect, which we tend to ignore. We tried to replicate, you know, what he did with Prash in Australia at Penn, and I regret to say we just didn't do as good a job. Our experience wasn't quite as good as his was. But I'm grateful that he's here with us today. I mean, this is really late for him. It's pushing close to 2 a.m. in Australia, but Rajiv is here, and I'd love to hear his take, as would the audience, on the feasibility of comprehensive risk factor modification in AF patients and whether that can really be done consistently. So Rajiv, the floor is yours.
Thank you, Sanjay, and Vinita and JP for the kind invitation. It's a big act to follow after such a stellar lineup. But I'll try and present my aspect. So the topic today is to talk about the efficacy and feasibility of comprehensive risk factor management and to see if we can improve the ablation outcome. I want to present the AF prevalence data and considering the Asia Pacific audience, we know that atrial fibrillation incidence has been increasing in Asia as well. And we can see this increase in almost every population subgroup. We know that in aging population, this is a common problem, but we see an increase in much earlier age group as well. So the incidence and the global epidemic continues to rise. Cardiac risk factors are associated with increase in risk of atrial fibrillation. And in fact, with each increasing cardiac risk factor, the risk of atrial fibrillation increases exponentially, and it reaches, exponentially. More importantly, the relationship between atrial fibrillation and some of these risk factors is dynamic in nature. We see with an increase in weight, there is an increase in incidence of atrial fibrillation. But what's more importantly, if these patients lost weight, the risk of atrial fibrillation normalized in these patients. This led to our first group of study from Professor Pat Shander's group, where I did my PhD and we did our subsequent studies as well. This was first study from Hani Abed group. Hani Abed, who as part of his PhD did this randomized controlled trial where he looked at 150 patients, and they were randomized between patients who did usual control group and active intervention. These patients lost weight. They went through this protocol, which we all followed. We had weight management. These patients were educated for a permanent lifestyle change with a 10% weight loss being the target, increase in their cardiorespiratory fitness, dyslipidemia, sleep apnea was treated, their blood pressure was monitored. They were started on ACE inhibitors with a target of less than 130 of 80 blood pressure. The blood sugars were monitored, and their diabetes was managed. Smoking cessation and alcohol abstinence, if possible, or less than 30 grams per week was tried to be achieved. So this was comprehensive risk factor management, which was tried to be delivered through a clinic. What we saw in the short term, that with intervention, we had a significant reduction in the atrial fibrillation burden. This was associated with reduction in number of episodes and the total duration of atrial fibrillation. We were then interested to see if these effects can be seen in the long term. Can we see these effects which can be sustained? And also, was there any dose effect of the weight loss? So we divided the groups into 3 different groups: patients who did not lose weight or had a weight gain, patients who had 3 to 9% weight loss, and patients who had more than 10% weight loss and achieved a BMI of around 27. We looked at our data, and here we can see that patients with more than 10% weight loss, nearly 50% of these patients, and this was about 50% mix of paroxysmal and persistent atrial fibrillation patients, they remain free from atrial fibrillation at nearly about 3 to 5 years' time without ablation or antiarrhythmic medication. And with ablation, these patients, if they had more than 10% weight loss, they managed 86% of the patient maintained sinus rhythm. So we found that more than 10% weight loss was associated with dramatic increase in AF-free survival. We were then also interested to see if increase in cardiorespiratory fitness in these patients will, number one, reduce their weight cycling, or had an incremental effect on the weight loss and overall maintenance of sinus rhythm. So these patients underwent a graduated exercise program, which was individualized and structured for that particular patient. The frequency, the intensity of exercise, the duration of exercise, and type of exercise was really age and ability matched and prescribed for that patient. And they all had this heart monitor so that we can monitor their rate and actually monitor their exercise and their performance. What we found, if they managed to gain 2 MET in cardiorespiratory fitness, there was improvement in AF ablation outcome at the follow-up. We also wanted to see if this effect was on top of what we normally see with the weight loss. So here in this Kaplan-Meier curve, as we can see, with the 10% weight loss, which is the orange bar, in comparison to the blue one, which is less than 10% weight loss, there was 31% relative increase in AF freedom. This is drug and ablation-free AF freedom. When we put cardiorespiratory fitness gain on top of that, we saw that patients with weight loss or without, both of them had an improvement in their ablation, AF freedom. With those patients with more than 10% weight loss, we saw a 32% increase over and above the weight loss in their AF freedom. We know that AF is a progressive disease, and Dr. Marush was talking about progression of the scar. We know that this AF progresses from paroxysmal to persistent and permanent, and the substrate follows, and cardiac risk factors are associated with increase in this progression. In fact, with each additional risk factor, the risk of progression of the disease increases. In our reverse AF study, what we found, if these patients had weight loss and we managed their cardiac respiratory risk factors, that we could manage to halt their progression of the disease. In fact, what we found, that we can actually start reversing their disease, and patients with persistent atrial fibrillation started having shorter duration of atrial fibrillation, and they became paroxysmal. We all love to ablate, and doing AF ablation, we know, has a success of about 80 to 90% for paroxysmal atrial fibrillation. But when we look at the long-term data, as the previous, all the speakers were alluding to, we see an attrition of success, nearly reaching about 30% at 10 years mark. We hypothesize that the late recurrence of atrial fibrillation after AF ablation is due to progression of the underlying substrate. And if that is the case, aggressive risk factor intervention would improve the ablation outcome. So we looked at this data for patients who are undergoing AF ablation. And this was seen in ARREST AF cohort study. What we looked at, the patients who underwent aggressive risk factor management, and this slide was shown by Dr. Callans. So if patients underwent aggressive risk factor management, 62% of those patients managed to remain free from atrial fibrillation after single ablation, while only 1/3 of those patients who did not undergo this aggressive risk factor management after catheter ablation managed to remain free from atrial fibrillation. With multiple procedure, the difference again remained similar. That's why this has now become part of the guidelines. Weight loss, as in the guidelines, is useful for patients with atrial fibrillation, including those who have been evaluated to undergo AF ablation. So as a primary prevention or as a secondary prevention strategy, it can be utilized, and overall management of risk factors should be done in these patients and class 2A indication. What we have now done is use that as a unified message. So in our organization, both AF management and risk factor management goes hand in hand. While the patients are told about the rate control and rhythm control strategy and anticoagulation, at the same time, the operator will talk about risk factor modification and will encourage them to go to this risk factor management clinic, where a focused management of the risk factors will be undertaken. These patients will be given individualized and tailored exercise and diet program, and one-to-one counseling will be done to these patients. We looked at the clinical and cost effectiveness of this model. And we did this ICMR curve where we have bootstrapped and found in about 10,000 population, the way the bootstrapping is done, to see in what different scenarios we will be able to make it cost and clinically effective. And as you can see in this ICMR curve, in fact, most of the scenarios, the risk factor modification is going to be less expensive and more clinically effective. Dedicated AF clinics have been shown in different other models to be effective in getting better outcome for AF patients. This is Rom Heinrich's paper from Netherlands, where he had a dedicated nurse-led AF clinic with attendance of a clinician. And what they found in a nurse-led integrated care clinic, there were better outcome, reduction in hospitalization and death, a better guidelines adherence, both for anticoagulation as well as for antiarrhythmics in these patients. The Penn group, since I left, also looked into this, and it was a nurse-led clinic. It was starting at the time when I was there, and Sanjay has been instrumental in driving this. And it's really interesting to see that the patients who were enrolled, those patients had a better compliance, less weight fluctuation, and they managed to successfully lose 5% weight in a sustained manner. Whereas patients who declined, you saw a weight fluctuation, in fact, and some patients gained, others lost. Also, other risk factors such as sleep apnea were better managed in patients if they attended these dedicated clinics, because they were like an incentive. The clinicians identified those particular risk factors and the referrals were made, the compliance, the overall follow-up, all of those improved if there were these clinics. Now, integrated care for atrial fibrillation risk factor management is part of the guidelines, and it's two-way indication, but it's important to understand it's not one person who's involved in this. While the patient remains the center of focus, primary care physicians who refer, the dietitians, the endocrine specialist, the psychologist, pharmacologist, the sleep apnea specialist, and exercise physiologist, all of them have to work in unison with each other, and a tailored program has to be delivered for the patients so that they can continue to remain compliant and remain engaged in this overall process. So I'd like to conclude here, ladies and gentlemen, by saying risk factor management for atrial fibrillation is extremely important, and in fact, a new paradigm beyond rate and rhythm control strategies, and in fact should be seen as a fourth pillar in overall management of atrial fibrillation. It reduces AF burden and definitely reduces need for AF ablation as well. It improves outcome of rhythm control strategies. It is cost-effective and also clinically effective, and should be seen as essential for AF care. Thank you for, I'm happy to take the questions as well.
Rajiv, that was terrific. The talk obviously has generated a lot of enthusiasm. The questions are coming, and we'll save them for the discussion after our third speaker. But I just am so amazed that you look so fresh at 2 o'clock in the morning. And that is also remarkable. So I don't know how you did that, but maybe you are practicing comprehensive risk factor modification personally, which is probably the reason why you look so good. We're going to move on to our final speaker, Dr. Mohan Nair. Dr. Nair needs no introduction from me to the audience that is participating here. I mean, he's been a giant in the field of invasive cardiac electrophysiology for as long as I have been in cardiology. I remember when I left India in the 90s, he was already a well-known name in this field. I still remember during my fellowship at Penn, his paper defining or describing his experience with AF ablation in patients with mitral stenosis. And he was one of the early advocates of more extensive ablation involving the CS even at that stage. And obviously he's continued to build both his experience, his expertise, and just a few years back, he was the president of the Asia Pacific Heart Rhythm Society. And so it's really an honor and a privilege to have him join us. And we are on this side of the divide, very, very keen to hear about the Indian AF ablation experience. And so, Mohan, love to hear your thoughts.
Thank you, Sanjay. It's always a pleasure connecting with you. Thank you also for having me on the symposium, which is otherwise star-studded. I seem to be the outlier, but it is good to see. It is good to see what is happening in this AF field and the best of practices and the latest of trials and developments. But I will speak on what is happening in India, what we can do, and what we should be doing going forward. And that's, I think, the main theme of these symposia, the IHRS IHRS collaboration. And hopefully we could come up with some ideas and some collaborations with people like Sanjiv and others, so that we can move forward in our AFib ablation program. So what does the ablation landscape in India look like? The closest to reliable data is what comes out every year in the APHRS White Book. And if you look at the APHRS White Book in India, they're close to 1,000 AFib ablation done in 2014, and there's a 10 to 20% increase in the numbers over every year. We don't have reliable data post 2017 because of multiple factors. But you would think that at this point of time, if there was no corona pandemic, we would be doing about 2,000 atrial fibrillation ablation, or 1,800 to 2,000 across the country. A little bit surprising would be the fact that if you see the percentage of total EP centers or EP enabled centers versus centers which are doing atrial fibrillation ablation, this is just about 10 to 20%. And we'll need to discuss why this is so. Now, compare it with our friendly neighbor, China. Sorry. And you have numbers which are going on to almost 40, 50,000 atrial fibrillation ablation. Also, you'll find that 50% or more of their EP centers are doing or actively engaged in atrial fibrillation ablation. And so let's, if we were to correct this, we need to look, or at least try to understand and discuss reasons why this could be so. So I'm just going to throw my views. JP is there, I'm sure. Dr. Vanita is there. I think Yash is also attending, and they could put in their impressions on where we should remain at this, or we should try to come here. Now, it's not that we don't have enough EP centers that can do atrial fibrillation ablation. Close to 100 EP centers are 3D enabled and are doing very good work in terms of ventricular tachycardia ablation, in terms of atrial tachycardia ablation, and even ablation in congenital heart disease. And it's not that we don't have some of the cutting edge technology that was presented a little earlier, but most of what we want in terms of 3D mapping, high density catheters, contact force catheters, they're all fairly easily available in India, of course, for a price. And cryo is knocking at the doors. And that again, I think has got stuck because of financial issues, but it's a matter of time and before we get cryo also on board. And yet our numbers are what they are. So I'm just doing trying to understand why this is so. One reason could be that if you look at our population, we have a pyramid which is bottom heavy. So what happens is that if you remove the rheumatic or structural heart disease AFib, the other lone AFib or age-related AFib, the population is already down at this level. And even if the person out here looks at an invasive procedure for AFib, they're actually looking at another 10 years of life. And that could be a reason why there is a little reluctance on the part of referring physicians as well as patients to get an invasive procedure done around this time. As opposed to that, you look at China, you have a different population demographic. It's middle to top heavy. And you know that they are trying to change this by some very drastic laws or policies, because this kind of a pyramid has its own drawbacks. But you see here, there are plenty of people in this age group, 65, 70, 70, 80, 90. So this means that they start with population demographic where the number of people having atrial fibrillation, which is age-related or lifestyle-related, is more, and those patients are looking at living for at least 20 to 30 years. The other reasons could be that as both physicians and patients in India want a single shot perfect solution, they're all very happy getting a SVT ablation done. It's just one, come in the morning, go out in the evening, and you don't have any SVT anymore. But atrial fibrillation is a progressive disease, and you can't really, many people may have a recurrence, more recurrence than what we have in, say, atrial tachycardias, SVTs, and atrial flutters. And that could be a reason that they don't want to come back and have a second procedure. And physicians don't want to do a second procedure too, perhaps. And that could be one reason why the numbers are not where they should be. I'm not saying that we should be at high numbers. This could be a very well circumspect decision not to do by physicians. And but that explains the numbers. Another reason is that if you want to have a good outcome, you need to spend some time in the cath lab. And even now, I think there are quite a few of these electrophysiology labs. Even now, it's improving, but even now, we're sharing space with the interventional colleagues, and it seems that doesn't work because doing an interventional procedure looks so much more dramatic, so much more cost effective, so much more beneficial to the patient in the immediate. That might be holding back some of our young electrophysiologists from doing more atrial fibrillation work. However, we must understand that none of us, including all our IHRS senior members sitting here, we've not been away from the science of atrial fibrillation or even science of atrial fibrillation ablation. Like JP just said, they're already looking at fibrosis, rheumatic atrial fibrillation. They're actively trying to see whether they can have a sustainable, reliable atrial MRI to try and find a solution. And we've been also looking at atrial MRI for some time, but are still struggling with it as of now. So we are not away from the science, be it medical therapy or ablation. And we've been part of several phase 3 trials looking at both novel energy solutions or energy delivery solutions with catheters or novel mapping catheters for, I'm sticking just to the atrial fibrillation arena. Now, that's where the general atrial fibrillation ablation story in India is. Coming to persistent atrial fibrillation, we have a special interest in rheumatic heart disease and persistent atrial fibrillation because the numbers, although rheumatic heart disease itself seems to have gone down a bit, but the IHRS AFib registry that was done about in 2014 or maybe 2013 did show that close to 50% of our atrial fibrillation load is still rheumatic. And we need to do something for this because these kids are very young and they would live with this atrial fibrillation for at least 40, 50, 60 years. So in the 1990s, 1995, 1996, we first, as a first step, tried to put in a lot of catheters. We didn't have 3D mapping at that time. Put a lot of catheters in CS and pulmonary veins and in the right atrium, just to see the patterns of atrial fibrillation that we get, just to find out whether there is a window of opportunity to ablate rheumatic atrial fibrillation. What we found was most of the places, most of the time, were in type 3, Wells type 3 atrial fibrillation. That's grossly disorganized activity with no organized, both in terms of baseline changes and atrial electrogram changes. The Indian atrial septum seemed to be showing more organized activity, but that was not necessarily temporally stable. So with this data, we couldn't really get a key to how to ablate this rheumatic atrial fibrillation. So then what we did was we just wanted to see if we convert this atrial fibrillation into sinus rhythm and then study the recurrence of atrial fibrillation. And there we found that there was invariably the reinitiation in almost all patients occurred with a flutter. This flutter came from different sites. It could be from the coronary sinus, it could be from the inner atrial septum, or anywhere in the left atrium. Again, at that time, we were limited by access to the left atrium, both in our experience and by the lack of three-dimensional mapping systems. So we just, among those flutters that we saw, we mapped and entrained the flutters which were arising from the coronary sinus and were able to ablate. And this, then, as I said, we don't go anywhere in the inner atrial septum or the left atrium at that point of time. We were able to ablate, and in the lab, 6 out of 14 patients were non-inducible. These are patients who showed predominantly reinitiation in the coronary sinus region. This was published, like Sanjay said, and more than interest, there was a lot of skepticism, cynicism, and critique, and all very well placed. I fully accept that this was not something, this was perceived as a solution to atrial fibrillation ablation in rheumatic heart disease. It was not. But yeah, the more criticisms you get, the better you become. So setting about the criticisms, we have to accept that a lot of these patients, if you carefully see, do have periods of this very stable rhythms, either during their chronic AFib, persistent AFib, or just before getting into persistent AFib. And over the years, several institutions have published these ablation, mapping and ablation. This is now in the 3D era, more, and also, of course, far more electrophysiologists, some of them very young and brilliant. So we have increasingly reports of this kind of flutters, which are ablated as a policy to preempt the development of atrial fibrillation. And also, I saw this very interesting publication from Bordeaux. They talked about localized sources, not after cardioversion, but after previous ablation. And when I looked at some of the maps, they seem to look similar. And in that study too, they ended up closing the atrial fibrillation by a second ablation in the near the coronary sinus or in the LA, wherever they found this found these flutters, or whatever you want to call them, organized AFib or flutter. Now, of course, that was not good enough to keep these patients in sinus rhythm, and so we then jumped into the bandwagon of doing whatever you could. We focused initially on PVIs and cafes, and also, of course, ending up with right-sided lines. As JP said, rheumatic atrial fibrillation is not necessarily all left-sided. So the cafes were done with a 2 millimeter catheter to increase the fidelity. And a lot of times, a wide antral ablation took care of a lot of areas of cafe. And once we ablated, we remapped to look for cafes that might have been left back in the previous thing. So it was done very meticulously, step by step. And what we found was that when we did this, there could be 3 or 4 outcomes. One, that the atrial fibrillation just did not change. The second, that you could have sinus rhythm in the lab. Or most commonly, you could have more organization of the atrial electrograms. So the fibrillation actually goes on to flutter, a form of atypical flutter, actually. And this could then be mapped in some cases. We would typically take flutters which had 220 milliseconds or more cycle length. And those who had less, that is faster flutters, we cardioverted and just left them on follow-up. This again was published, but again, as has been discussed, and this is our problem, that while the acute results could be good, the long-term post 1 year results, we could have never exceed 50% of sinus rhythm maintenance. We have tried a few tricks, and we are looking at a few more tricks. And I just heard some fantastic new technology that could be used. And hopefully, when I say we, I talk of India, not my own work. I think somewhere we will start improving success rates in rheumatic AFib as well. While catheter ablation has not been a great procedure, invariably across India, the small pilot studies across Asia and the US, intraoperative procedures during valve surgery have had fairly acceptable acute, and more importantly, long-term maintenance of sinus rhythm. And that again gives us hope. A case in point is a very senior cardiac surgeon from Delhi, very senior, very well known. He had mitral stenosis, he had a CMV, that's closed mitral valvotomy, then a BMV, and then he had a LA of more than 50. And terribly symptomatic atrial fibrillation. A lot of people told him, you don't even think about any procedure. But 2 years back, he went to New York and got a thoracoscopic atrial fibrillation ablation and also a mitral valve repair. And I just talked to him a couple of days back also. He's in perfect sinus rhythm. So there's something that we are not able to do by catheter that the surgeons are able to do. So it's not all lost in terms of rheumatic AFib ablation. And this, again, is an interesting study from China, where they did, these are all patients with long-standing rheumatic heart disease, all who were undergoing surgery. The group A had catheter ablation before surgery, group B had ablation at surgery. They found that recurrences were higher, or the need to a second procedure was more in the group A, that is people who are on catheter ablation. But after, if you had the second or third procedure done, at 4 years, 80 to 90% or 80 to 85% remained in sinus rhythm. Again, a very, very encouraging study. So we need to actually see what we can do to break this roadblock. And so to end, I think while we can be contemplative and a little conservative in offering ablation as a treatment or treatment for atrial fibrillation, I think very clearly even by those standards, our numbers are low. And we need to sit together and try to find a way to be able, and we cannot find a way if we don't honestly address the issues at hand. Persistent atrial fibrillation, as all the stars in the previous talks and all the fantastic studies that were very beautifully discussed, so continue to be a problem. And that would include rheumatic heart disease. So I think that's a work in progress. But seeing all the technology and the hunger to understand the reasons for recurrence and the basic pathophysiology and the electrophysiology in atrial fibrillation makes me believe that it's just a matter of time before we break the glass ceiling and bring up rheumatic atrial fibrillation ablation as a viable treatment modality. Catheter ablation as a viable treatment modality for rheumatic atrial fibrillation as well. IHRS, as I said, I mean, this all doesn't mean that nobody is doing or trying. IHRS has been very, very active on many fronts. And one of the good things that has happened in the, I don't know whether it started, but it's happened a few months back, that IHRS is, among other things, backing a registry for ablate and pace in RSD. Now, if you see the white book, most countries which have good numbers and good data have registries for almost everything. There is a column where you say, do you have a registry? No, yes, no, yes, no. In India, we have, I'm sorry to say, did not have too many registries. And that might be the reason why the data is a little weak. More importantly, I think putting people together in registries pushes scientific, pushes much better of the scientific data. Perhaps we will reach the right numbers for this wonderful science of atrial fibrillation ablation. Thank you very much.
That's great, Mohan. Very insightful and certainly gives us a better understanding of what's happening in that part of the world. So, JP?
Very nice talks, all of you. I think we should congratulate all the speakers for having given fantastic talks. Now, one of the questions to Dr. Atul Verma. Now, for we have a lot of these young electrophysiologists in the group. What would be your advice as to how to approach, an AF ablation? Would you want to do the whole thing, all the lines put together, everything, or just do the PVI alone for these patients? How would you what would you suggest for persistent as well as, paroxysmal AF? How should a youngster go about it?
Yeah, so that's a great question.
We should probably differentiate between novice versus an experienced person here.
Yes, of course. So I think that's a very, very good question. And I think that in discussing this with a lot of my colleagues from around the world, most people will say that for a first procedure, it's absolutely critical to get a good, high quality, wide antral isolation, PV isolation completed. So all 4 veins done meticulously, done well, with a 20-minute waiting period afterwards to ensure that there's no reconnections, plus or minus the use of adenosine or other provocative measures. And whether you choose to do that with cryoballoon technology, RF technology, whatever technology is available in your jurisdiction, I think that is absolutely key. And once you have absolutely mastered that approach, where isolating veins is like rote memorization, you get 4 out of 4 veins isolated each and every time, that's the time when we can start considering to add other strategies. Because, at the end of the day, if we don't get the veins right, and the veins are going to just reconnect, or you're not going to completely isolate the veins, and anything you do beyond that is really not going to help. So I think for someone that's new, youngster, starting off, you know, that's what I would really emphasize is you know, it's like memorizing your times tables in elementary school before you can start to do calculus. You know, it's it should become like muscle memory. And when that is absolutely perfected, then start exploring. And more importantly, when you start exploring other targets, do studies. You know, for a youngster who's starting off and they want to establish their credibility, they want to publish, they want to become known, start doing studies.
Right. Now, Rajiv, excellent, you know, studies which have come out from your center, and Prash was my junior, incidentally.
Right,
you have done a great job. You know, it brings us important aspect of you know, the risk factor modification, which is often sort of put aside by most of the ablationists, at least so-called ablationists who don't look at the risk factor modification. Now, how long would you do the risk factor modification before you would suggest a patient for an ablation? And the second question, what is the role of bariatric surgery here in a patient who is very morbidly obese before you suggest an ablation?
Thanks, JP. So the two questions, first of all, patient, how long will you wait and do an aggressive risk factor modification? So it all depends on the symptoms. Sometimes if the patients have symptoms and they have come and you know that there are obvious lots of risk factors, you will start addressing those cardiac risk factors and you'll see the effect. If they are starting to lose weight and they're managing sleep apnea, their AF burden starts to reduce, in those patients, you may delay the catheter ablation. Sometimes all these cardiac risk factor management are in addition to the catheter ablation, which they will probably need anyway. So those subset of patients, you're proceeding with catheter ablation, and the journey of risk factor modification continues in parallel in those patients. And risk factor modification will continue even after catheter ablation. Those are two different studies looked into this. So legacy study, we looked at before catheter ablation, and we looked at 40% of those patients who did not require catheter ablation at all, at least in that 5 years period. And then ARREST-AF cohort patients, those patients where risk factor modification and AF ablation almost went side to side. So patients come for catheter ablation, those patients have been given date, and we had about 3 to 6 months waiting time. And during this time, they're having aggressive risk factor modification. They lose weight or in process of losing weight, but they get their catheter ablation procedure done as well. So that hopefully answers your question. There is no real target unless someone's AF starts to disappear. The second part of the question, I guess, was about surgical weight loss. And this is study from John Kalman's lab, and Krishan is the first author of that. He has shown that weight loss, even through surgical approach, can be highly effective. There are certain subset of patients where lifestyle intervention may not be effective enough. And those patients, surgical weight loss can be double-edged sword. Sometimes it has shown to have an inflammatory effect. However, if done properly and all other lifestyle modification are achieved at the same time, I think surgical weight loss can help reduce the AF burden in those patients.
A couple of my friends are concerned and want to know about alcohol and atrial fibrillation.
So this is Peter Kistler's paper from Austin in Melbourne. And yes, excessive amount of alcohol intake is associated with increased risk of atrial fibrillation. One, it's a cheap calorie. Number two, it's direct alcohol has an effect on the heart itself. So in our study, the aim was to reduce to less than 30 grams of alcohol per week. And that, I mean, this is a random number which shows 3 standard drinks a week. But Peter Kissler's work has shown that reduction in alcohol intake will reduce your burden of atrial fibrillation. I see Yash has a question saying, I had morbidly obese 40 years old with chronic AFib and controlment. I agree, absolutely. Those patients you probably have to hammer, Yash.
Rajiv, I had another question actually. Can you hear me?
Yes.
I had another question to Mohan, you and the other panelists. There are a few of these patients who we think that they are chronic persistent AFib, but we try rhythm control, we give amiodarone, we do cardioversion, and they don't convert. You know, the atria are not that large, so we think it's worthwhile trying. And then we give up, we stop the amiodarone and do rate control, and they come on follow-up and they're in sinus rhythm for quite a long time. Have you experienced this? Patients, you try everything, nothing happens, and then on their own they go into sinus rhythm sometimes. I've had another patient who got an ICD shock, was my moderate MR, chronic AFib, got an ICD shock and then remained in sinus, appropriate shock for VT, and remained in sinus rhythm for a couple of years.
Yes, yes, these are anecdotal cases, and sometimes I myself surprised how on a certain follow-up the patient is in sinus rhythm and continues to do so, and after some time actually goes out of my regular atrial fibrillation clinic. But the specific patient that you're talking about, you gave amiodarone, cardioverted, and then the patient remained in sinus rhythm. As with any intervention that looks at restoring sinus rhythm, it's very clear that the longer the patient remains in sinus rhythm, the lesser is a chance for a recurrence, whether it was because of drugs, without drugs, or with ablation, because I think there's atrial remodeling. So whenever a patient is coming on follow-up, I'm just praying that he remains in sinus rhythm for another 3 months. Another 3 months. So
what about ACE inhibitors and atrial fibrillation?
Pardon?
ACE inhibitors like ramipril and atrial fibrillation. I think this atrial remodeling reduces atrial fibrillation. I think there's a study on irbesartan. So I have started giving ramipril to many of my mitral stenosis patients, very low dose.
Okay. Mitral stenosis, I would be a little careful, but other mitral valve disease, yes, they're all on ACE inhibitors. And I will look into this and let me see if I can. We have started a protocol, I can't talk about it now, of using some medication which is out of the box for preventing atrial fibrillation. Let's see how that goes. But it's similar to what you're saying. On the same lines, but the drug is different.
I have a question to any of the panelists who would like to answer. Moderate mitral regurg and mitral valve prolapse doesn't need surgery, but now develops atrial fibrillation, which is persistent. But does that become an indication for surgery for the mitral valve prolapse?
Yeah, that's a very good question. You know, if you look at the American or even European guidelines on management of valvular heart disease, in the presence of mitral regurgitation, the development of new onset atrial fibrillation is frequently listed as an indication for proceeding on to surgery. The problem with that indication, however, is it doesn't really take into account you know, whether that atrial fibrillation is just a small amount, whether it's paroxysmal, whether it's persistent, whether you can cardiovert the patient and keep them in sinus rhythm for a period of time, whether the atrial fibrillation is worsening their symptoms or not. So that is always a very challenging one. But I think that if the atrial fibrillation is persistent, if it's worsening their hemodynamic status, worsening their heart failure, then that would be more of a pressing indication for surgery. We have certainly done ablations on patients with moderate mitral regurgitation when they're in the earlier phases, paroxysmal, to try and delay perhaps having to go for surgery. But I think when they're persistent and they're very symptomatic, it's probably a reasonable choice.
And one more question. I missed the initial part of the symposium, unfortunately, but I don't know if hypertrophic cardiomyopathy, I've had a few patients who've undergone at good centers, atrial fibrillation.
Yash, I don't know if you can hear us, but we lost communication from you.
Yeah.
Oh, sorry, can you hear me now? You got my question?
Repeat your question again.
In hypertrophic cardiomyopathy, I've had a few patients, and I'm sure all of you have seen lots of patients. The results of ablations, as expected, of course, are not. So which are the correct patients of hypertrophic cardiomyopathy who should be referred for ablation for AFib?
Dr. Callans has published on this. And so Dave, do you want to take this question? You're muted.
Okay. Sorry. So I think this is another great example of what we've been talking about, using old data to answer present questions. But with that aside, it really seems like the procedures for hypertrophic cardiomyopathy are much better before the onset of persistent atrial fibrillation. After that, it can be very difficult. We wonder if it's, or I wonder if it's a problem with not being able to ablate transmurally in the atrium from the endocardium. We see some, this came up in Atul's talk too, talking about hybrid surgical ablation. Even in non-hypertrophs, it's pretty clear that at least in some areas of the atrium, neither surgical ablation from the epicardium nor endocardial ablation with catheters can reach all the way through. And maybe the strength of hybrid ablation is really this meeting in the middle. I think that would be a very attractive way to go with hypertrophs with persistent atrial fibrillation. But again, I don't have a lot of experience with that.
I can add to this, David, is these guys progress very well, very fast. The progression of myopathy continues. You ablate them even for paroxysmal. If you image them again, start in a speed that faster than others. I think you should factor this in as well. I mean, not only it's hard to, but we published this early papers. Yeah, it's from Cleveland. I think Atul was there with us. Remember Fethi Kilkislan, Atul, he looked at this population. And paroxysmal do very well, as Dave said, but the progression of myopathy and recurrences, they continue to be a challenge because of progression of myopathy and atrium.
Yeah, and I think just to add to that, once the patient especially reaches that so-called burnt out stage of hypertrophic cardiomyopathy, where even the LV is starting to dilate and they're moving from a pure hypertrophic to more of a mixed dilated hypertrophic kind of picture. That's definitely a point of no return. We've tried to do some of those patients, and it's sometimes you really feel like it's an exercise in futility.
I think it's getting to that point where it's almost 3 o'clock in the morning for Rajiv, and it's getting close to 11 p.m. in India. But this has been remarkable. I mean, number one, just thank you to the faculty for joining us this morning, tonight, this evening, and really making this last presentation before we take the break for the summer just such a successful webinar. So thank you for that. And of course, to the audience in India, I know some have left, but the majority stuck around. So thank you for that. And I hope you benefited from your participation today.
Wonderful.
I want to thank Vanita, my partner in crime here. This is 1 year of effort that has translated into multiple presentations on a variety of topics. And so thank you for doing this, Vanita. And of course, the Indian Heart Rhythm Society for allowing us to develop this platform. We're going to take a break, as we said, for the summer. Things are opening up, at least on this side. We all hope that, things start opening up in India, and then we can, regroup and decide how to continue this collaboration. But I just want to express my gratitude for letting me do this, and I hope it was worthwhile for everyone.
Thank you so much, Dr. Sanjay. That was really great. Dr. Yash, please, sir.
Yeah, I think we also hope, Sanjay and others, that to open up soon. I know once things open up, these webinars may become less frequent, but I think the Indian Heart Rhythm Society has really, and thanks a lot. I mean, a great deal of credit goes to Vanita and Sanjay. I mean, throughout these 18 months of torture, have kept our spirits up with these webinars. And everyone, seniors, I can see JP, Mohan, so many have participated, and I'm sure so it has. I don't know about the HRS, but I see very few other societies in arrhythmia which have managed to keep up the tempo the way you guys have. So we should continue this effort. Of course, if things open up, it will not be so frequent. We understand that, but it has been so far a fantastic journey. Thank you very much.
Thank you, Dr. Yash.
Yeah.
Thank you so much, everybody. I think we'll call it off. It's going to be 20 minutes to 11 now. And Dr. Sanjay, it gives you a 2 months break, but I'll be in touch with you. I'll again drag you into this so that we can plan something again for the future. It's not a goodbye. It's good night.
No, not at all. I'm happy to help. But again, I think just want to thank the faculty, because all of them have given their time selflessly with no expectation, for which I'm really grateful to the panel today and all the other faculties that have participated up until now. So thank you, guys.
Thank you, Sanjay. Good to see you.
Thank you. Fantastic.
Thank you very
really
much.
enjoyed
Yeah,
it.
Really enjoyed it as well.
Marvelous. Best of luck. Thank you.
Great meeting. Thank you, everybody.